While the basic Williams-Marrow mnemonic helps identify the patterns, the clinical implications of right bundle branch block and left bundle branch block differ significantly. Williams refers to left bundle branch block, W V1, a deep wide S wave or QS complex resembling W. LL for left bundle branch block. M in V6, a broad notched R wave resembling an M. Marrow refers to right bundle branch block. M in V1, an RSR pattern, so-called bunny ears, resembling an M. RR stands for right bundle branch block. W in V6, a wide notched S wave resembling a W. Maybe this part is too much of a simplification, as you seldom see a W pattern in V6 in RBBB. The most profound difference lies in how these blocks affect the heart's pumping efficiency. LBBB causes dysynchrony. LBBB causes the interventricular septum to depolarize from right to left, leading to septal flash. The right ventricle contracts first, pushing the septum towards the left, which then bounces back. This ventricular dysynchrony significantly reduces ejection fraction over time and can lead to heart failure like dilated cardiomyopathy pattern. RBBB, benign asynchrony. Because the left ventricle is the primary pump, still depolarizes normally and early. RBBB usually has minimal impact on overall cardiac output. The right ventricle eventually catches up via cell-to-cell conduction, which is slower but less hemodynamically taxing. Ischemia masking effect is probably the most critical distinction for acute care. ST segment interpretation is generally reliable in right bundle branch block. You can usually see ST elevation in the setting of an acute MI. In LBBB, it is unreliable. The massive repolarization abnormality masks standard STEMI criteria. Q waves. Initial septal depolarization is intact. Q waves remain diagnostic of old MI. Septal Q waves are lost in LBBB. New LBBB is often treated as a STEMI equivalent in the right clinical context. Diagnostic aids. Standard ECG interpretation in RBBB. In LBBB, you require Sgarbosa criteria or Smith-modified Sgarbosa criteria to identify ischemia. Looking at the electrical axis provides clues about the severity of the conduction system disease. RBBB plus left axis deviation. This suggests bifascicular block. RBBB plus left anterior fascicular block. Since the right bundle and left anterior fascicle are both supplied by the left anterior descending coronary artery, this pattern often signals significant LAD disease. LBBB is rarely an isolated finding in a healthy heart. It is almost always a marker of underlying structural disease like hypertension, ischemic heart disease, or valvular heart disease like aortic stenosis. The discordance rule. In LBBB, the ST segment and T wave should always point in the opposite direction of the terminal QRS complex. If you see a positive QRS with a positive T wave in LBBB, that concordance is a major red flag for acute ischemia. R prime in V1 and slurred S in V6. In RBBB, R prime in V1 and the delayed slurred S wave in lead 1 and V6 represents the slow arduous journey of depolarization across the right ventricular myocardium. Isolated RBBB rarely requires a pacemaker. However, a new LBBB in a patient with syncope is a high-risk scenario which might eventually need a pacemaker, especially in the setting of transcatheter aortic valve implantation. Left bundle branch block with heart failure can be an indication for cardiac resynchronization therapy. By pacing both ventricles simultaneously, we can fix the electrical delay problem and physically shrink a dilated heart. RBBB patients with heart failure typically do not respond as well to CRT.